Wait.
Yeah.
Dr. Sima will start. Huh?
We'll formally
Okay,
welcome
after
you, Dr.
boarding it, we
Lakshay. Don't
start.
worry. So, good afternoon, everyone. On behalf of Satluj Academy of Pediatrics, the State IIP chapter of Punjab, welcome all of you on the case presentation series that we conduct on each Thursday, last Thursday of the month. In this series today, we have an excellent team from CMC Ludhiana, headed by Dr. Monica Sharma, and moderator is Dr. Niti Gupta, and presenter is Dr. Lakshay Sharma. And for this, we have expert of the day, Dr. Venkatesh, from senior neonatologist from Manipal Hospital, Bangalore. For this, we have our president, respected Dr. Gulshan Srinara. I request sir to formally start the meeting and official welcome of the team. Over to you, sir.
Thank you, Dr. Sima. The most attracting thing today is the name of the case, the heading of the case, oscillations through life. So we can start listening. What are these oscillations? What has happened to the baby in the CMC and how the baby has recovered? Dr. Sima, we can start.
Okay, sir. Now over to Dr. Niti Gupta for the further proceedings.
A very good afternoon to everyone. This is indeed an honor for me to be given this opportunity to moderate this session. I owe this gratitude to the president and other eminent members of the Satluj Academy of Pediatrics. Now I like to welcome Dr. Monica for few words. Dr. Monica is our HOD and she is graciously mentoring this session. So, Dr. Monica, ma'am, please
Thank
say
you.
a
Thank
few
you,
words.
Nidhi. Not being a practicing neonatologist, I find it very fascinating to hear about how HFO works. And therefore, I had welcomed Dr. Nidhi to moderate this session. And I'm looking forward to learning something more from Lakshay and yourself. Thank you so much.
Yeah, now I would also like to invite my mentor from my DRNB, Dr. Venkatesh Chache. He is a renowned neonatologist and an academician. He has authored numerous publications, and he is, even after being that extraordinary achiever, he is remarkably humble, approachable, and deeply inspiring as a teacher and a mentor. I welcome you, sir. We
Thank you.
welcome you.
Thank you so
We
much.
all welcome you from CMC Ludhiana. Thank you for agreeing to be a part of this event.
Thank you, Dr. Monica Sharma. Thanks a lot.
Dr. Laksh, you can start the case.
So good afternoon, a very warm welcome to all. So today we'll just deal with the journey of an unit who actually improved on HFO. I am the presenter and moderator being Dr. Nidhi Gupta and my mentor being Dr. Monica Sharma. So expert being Dr. Venkatesh. He's a consultant neonatologist working as a head of Department of Neonatology in Manipal Hospital. So we have a term male neonate who was born to a 30-year-old gravida 5 para 2 live 2 abortion to mother at 37 weeks and 1 days of gestation by
Shagun?
LSCS, indication of LSCS being previous to LSCS in labor. So this baby was born with a birth weight of 3180 being appropriate for gestational age. This mother was a 30-year-old. She was a booked case at CMC, our hospital. She presented at 37 weeks and 1 days of gestation. Her pregnancy was confirmed by urine pregnancy test. Her last menstrual period was 2 June of 2025 and expected date of delivery was 9th of March of 2026. When we come to the antenatal history, in the first trimester, there was no history of any fever with rash, no history of any bleeding or discharge per vagina. There was no history of any radiation exposure, drug intake, or any desi medication intake. There was no history of any alcohol or substance abuse. And there was no history of any high BP or sugar recordings. There was no history of hyperemesis gravidarum. No USGs were done in the first trimester. Coming to the second trimester, there was no history of any pedal edema, headache, epigastric pain, swelling of feet, blurring of vision or palpitations. No history of any seizures, no history of any polyphagia, polydipsia, polyuria. There was no history of pain during micturition, no history of joint pain with rash. There was no history of any renal disease, and fetal movements were first perceived during the 5th month of pregnancy. Anomaly scan done at 19 weeks was normal. In the third trimester, Again, there was no history of any fever, no history of bleeding or leaking per vagina, no history of any pain during micturition, no history of features suggestive of any urinary tract infection or preterm premature rupture of membranes. She was a 30-year-old gravida 5 para 2 live 2 abortion to mother. She had one spontaneous abortion at 12 weeks in 2016 and a missed abortion in 2017 at 18 weeks of age. She has currently two live births, one 7-year-old live female alive and well, and the other 6-year live female alive and well. G5, this was the fifth pregnancy of mother. Medical history wise, there was no history of any hypertension, diabetes, TB, seizure disorder, or any respiratory problem in the mother. This baby was born on with by LSCS on 18th of February with an APGAR of 9 and 9 at 1 and 5 minutes at our hospital. Baby cried immediately after birth, shifted to mother side. Baby's weight was 3.18 kg. On examination, the baby was stable. He was clinically term, average size neonate. AFT level, CFT led 2 to 3 seconds. Peripheries were warm, pulses were well felt. No tachypnea, no distress. Eyes, ears, nose, oral cavity was normal. Hips, limbs, spine was normal. External genitalia normal male, bilateral descended testes. Umbilicus had 2 arteries and 1 present. Anthropometry wise, weight was 3180 kg, 90th centile. Height was 49 centimeter, which fell into 58 to 97 centile, and head circumference of 34.5 centimeter. Systematically wise, also he was normal. Chest had bilateral air entry present. CVS S1 S2 heard no murmurs. Per abdomen was soft. Liver 2 centimeter and spleen was not palpable for this neonate. So what happened next? At 2 hours of life, baby was found to have respiratory distress. We monitored the preductal saturation. At that time, preductal saturation was 80%. On examination, the baby was found to be in an unsatisfactory condition. He was found to be cynosed. Peripherals were slightly cold. Pulses were well felt, but tachypnea was present, rates up to 70, and mild subcostal and intercostal recessions were present. Audible grunting could be heard, and chest had decreased air entry on both sides. Downey score wise, he was in a score of 7. He was cyanotic in more than 40% FiO2. Air entry was slightly decreased. Grunting could be heard audibly with naked ear. He had recessions and respiratory rate of 70. So he was in impending respiratory failure. So this male term neonate was born. This male term neonate was admitted with NICU with a diagnosis of respiratory distress syndrome, query early onset neonatal sepsis, keeping a possibility of intrauterine pneumonia. He was initially kept on CPAP settings of 5 by 50, which were escalated to 6 by 50. Continued to have distress, was intubated, started on IV antibiotics, injection, second line antibiotics, Piptaz and Amica after sending the septic screen.
Dr. Lakshya, what happened?
Actually, I'm not able to go ahead.
Hello.
Slides are not moving.
Sometimes if you stop sharing and restart, then
No,
it
no,
starts.
I think so now you could do that.
Kar lo.
So this male term neonate was admitted to NICU with a diagnosis of RDS. He was initially kept on CPAP settings of 5 PEEP and 50 FiO2. Continued to have distress, was intubated and started on IV antibiotics after sending septic screen. When we did the investigations on admission, after shifting to NICU, HB was 21.3 against a PCV of 64.1. TLC was 19,600 and a platelet count of 237,000. ABG done on admission was normal, lactate of 2.6. Otherwise, CRP at 2 hours of life was 0.52. We sent a high vaginal swab of mother, keeping a suspicion of sepsis that also came as no growth. And IT ratio and ANC, absolute neutrophil count was within normal limits. PBF wise, predominantly normocytic normochromic. RBCs. WBCs were adequate and platelets were also adequate with normal morphology. So this was the X-ray on admission. We kept a suspicion of RDS in a term baby, which is very rare, and we eventually started with the respiratory support. So on day of life 1, keeping the RDS as diagnosis, surfactant administration was planned at 4 hours of life, but parents refused. Then he developed multiple episodes of pulmonary hemorrhage at 13 hours of life, for which we gave fresh frozen plasma. And baby had posturing and with tachycardia and desaturation at 20 hours of life. We did a RBS at that time, which was 134 normal, and serum calcium levels were sent. Seizures were aborted with midazolam, and he was loaded with injection phenobarb, and the maintenance dose of phenobarb was continued. Antibiotics were upgraded to meropenem and vancomycin, considering the flare of sepsis after sending repeat blood culture sensitivity. So CRP, which was 0.52 at admission, rose to 11.59 at 24 hours, and it gradually rose to 52 at 42 hours of life. Day of life 2, despite escalation of ventilatory support, SIV mode with higher settings of PIP of 18, PEEP of 6, FiO2 of 90%, with high oxygenation index, necessitated the transition to HFO, high frequency oscillatory ventilation, where we kept the settings of IE ratio 1:2, MAP of 16, delta P of 22, and FiO2 of 90%. And we started with minimal enteral nutritions along with oral colostrum application. So this was the failure of conventional ventilation, worsening oxygenation despite maximal conventional exhalation with a PIP of 18, PEEP of 6, and FiO2 of 90%, which necessitated the child to be transitioned to the rescue, which came as a rescue actually for this neonate, transition to HFO mode, where we kept the MAP of 16, amplitude of 22, IE ratio 1:2, and FiO2 of 90%. After stabilization through HFO, there was no further endotracheal bleeding. 1 dose of surfactant, that was Furosof, was given through endotracheal tube at 25 hours of life. This picture demonstrates the various insults of various systems the baby had. CNS wise, he had seizures, he had posturing, stiffening, desaturation at day of life 1. Then respiratory wise, we suspected intrauterine pneumonia. The stress was there, Downey's was 7. There was pulmonary hemorrhage. Then CVS wise, he had septic shock, BP, which I'll just talk in some time. And systematically, early onset sepsis was suspected. Along with that, there was a severe CRP surge. There was profound hypocalcemia, serum calcium was 5.43, and hyponatremia. So on day of life 3, the baby developed features of septic shock, including persistent tachycardia, cold peripheries, and blood pressure around 5th centile for gestational age. Baby was started on inotropic support with adrenaline infusion at 0.1 mics per kg per minute, and antibiotic was upgraded after sending again repeat colistin, after sending blood culture and sensitivity. So this was the sepsis parameters, the actual sepsis journey the baby went through at day of life 1, at 2 hours of life, which the CRP was 0.52, which actually escalated from 2.38 to 52.21, observed at day 3 of life. So it eventually piptaz amica, which was second line antibiotics, were added, and they were escalated to meningitic dose in keeping in suspicion of seizures. Miro and Vanco were added. Eventually, at day of life 3, the baby developed shock, features of shock. So we started on inotropic support, and simultaneously all the possible complications could be managed. Broad spectrum colistin was added, keeping susceptibility of worsening of the hemodynamic parameters. Eventually, all the blood cultures finally came as no growth, and baby was discharged with complete clinical hemodynamic stability. So on day 4 of life, as I told, ventilatory settings were tapered and baby was put back on SIV mode because he improved with HFO and surfactant, initiated on minimal trophic feeds. Neurosonography was done on day of life 4, which was normal. Baby was put on CPAP. He developed respiratory distress and desaturation, so he had to be reintubated. But and he developed icterus also, which was so he was started on phototherapy after sending total bilirubin. So this was the respiratory recovery and weaning cascade. After starting from CPAP, escalated through SMV, maintained on HFO, held surfactant held in between. The baby was able to be finally we were able to extubate the baby to CPAP following satisfactory ABG on minimal settings. Day 7, the CPAP actually was changed to oxygen by hood, and yes, on day 8 he was maintaining on room air. So he was started on KMC, kangaroo mother care, and feeds were also established. Baby did not had any further seizures episode, hence phenobarbitone was tapered and stopped on day 5 of life. Hemodynamically, we were able to stabilize the baby. Trigger was on day of life 3. We started inotropic support. It was tapered. It was stopped on day of life 6. Baby was hemodynamically stable. We were able to manage CNS complications. He had stiffening, desaturation, immediately aborted. Ultrasound, neurosonogram was normal, seizure free. Phenobarb also stopped on day of life 5. This was the respiratory battlefield, as I mentioned, starting from higher CPAP settings, deterioration through SMV, eventually pulmonary hemorrhage happening, and then HFO coming as a rescue. And we were able to give surfactant on time. Eventually, transitioned back to SMV, extubated to CPAP, tolerated it, sent on oxygen via hood, and finally discharged on room air, maintaining a stable saturation. With clinical improvement, including the resolution of shock, inotropic support, as I told, was gradually stopped, shock resolved. Day of life 7, respiratory support was weaned off, respiration better. Day of life 8, baby was initiated in KMC and breastfeeding, and feeds were established. So this is the before X-ray when baby was admitted with us. So it shows complete whiteout lungs, and there is a time when HFO and surfactant helped, and this is the day of life 3rd X-ray when the baby actually improved with the help of HFO. Direct breastfeeding was initiated on day of life 9. This was well tolerated. The baby was subsequently transitioned to spoon feeds and breastfeeds. This Mirovanco were continued for a total duration of 9 days and colistin for 7 days. And finally, antibiotics were discontinued after completion of the planned course. So this is the 9-day NICU trajectory. The baby suffered a lot of crisis stabilization, respiratory support from CPAP to SMV to HFO, finally to room air. Shock resolved, started on day of life 3, resolved on day of life 6. Seizure started on day of life 1, day of life 5, he was seizure free. We stopped phenobarbital. Started on total parental nutrition, eventually coming to minimal ventral feeds at day of life 4. Eventually a full feeds on day of life 6, and finally transition to KMC and breastfeeds on day of life 9. So we were able to discharge the baby. So this was conventional versus HIV mode of ventilation, which I'll just talk a bit about, and we have our expert. He'll just tell us what else we can add in HFO. So if we come to the difference between conventional and high frequency, as we know, physiological breaths are there in our conventional ventilation, but yes, SFO is a modality which uses supraphysiological rates and higher tidal volume and small tidal volume, and these tidal volumes are less than anatomical dead space. These rates are very high, so they are actually referred to in hertz, the units of frequency, and 1 hertz is almost equal to 60 breaths per minute. Most important is that expiration is an active process in high frequency oscillatory ventilation. These pressure waveforms attenuate as they reach alveoli. And the most important is in HFO, we can independently regulate the oxygenation and ventilation, which are actually coupled in conventional ventilation modes. The dual pillars of control, we have oxygenation and ventilation as the main key. So MAP and FiO2, these are the two main determinants of oxygenation in case of HFO, and amplitude and frequency, they are the main determinants of ventilation in case of HFO. Initial settings, as they are usually identified as, we keep a MAP of 1 to 2 centimeter higher than conventional in RDS, homogeneous disease, frequency wise 10 to 12 hertz in preterm and 8 to 9 hertz in term. FiO2 is same as conventional. In case of pneumonia, it is same MAP, but frequency as 10 to 12 in preterm and 8 to 9 in term. FiO2 is same as conventional. Air leaks, we have to keep MAP less, and FiO2 higher than conventional. So in case we are suspecting a poor oxygenation, as we have told that MAP and FiO2 are major determinants of oxygen. So poor oxygenation, we can increase both the parameters. If it is over oxygenation, we can decrease both parameters. If it is under ventilation, as more frequency, more rate, so increase amplitude. If it is under ventilation, and if amplitude is maximal, we can decrease the frequency. And in over ventilation, we can decrease the amplitude delta p. If amplitude is maximal, we can increase the frequency. So this is how our neonate from admission recovered, and we were able to discharge. And over to sir now for further discussion.
Shall I start?
Yes, yes, sir. Yes, sir.
Yeah,
You
yeah,
can ask the questions. Yes,
yeah,
sir.
yeah. So, Dr. Laksh,
Yes, sir.
thank you so much for presenting an interesting case. But what do you think that interesting in your case study? What is very important, highlighting importance?
Sir, the transition from SIMB to HFO, which
No, no,
in
no.
spite of,
I'm not asking. You started with what? Go to history. Go
sir,
back to
it,
history.
it is the uneventful antenatal history of the mother.
Why did you ask gestational age is important in this? Do you see commonly pulmonary hemorrhage in term unit? Commonly now at the moment. When I was doing my PG days, I used to see a lot, but I don't think you see in term babies. Did you
Having
ever
art.
get surprised why this baby developed pulmonary hemorrhage? You never did anything. You are a wonderful boy. You baby sailed out and you just shifted. You are watching. Suddenly, baby developed distress. Correct.
Yes, sir. Yes, sir.
So what is the thing here? In preterm, we all know that nowadays what we see is the preterm babies, severe RDS, not given antenatal steroids, and the pulmonary pathology is so bad that homogeneous lung disorder, and that is actually given to room for pulmonary hemorrhage. Though we blame surfactant we gave, and that's the reason pulmonary hemorrhage happened, isn't it?
Yes, sir.
But in term neonatal, when I was a PG, I used to see a lot of pulmonary hemorrhages. What is interesting topic in this time, at this point of time, having pulmonary hemorrhage in a term neonate we are talking about.
Yes, sir.
That is the thing here. That is very interesting in your topic. And why do you think that birth weight is important? Do you know that? Is it required? You knowing that appropriate for gestational age and small for gestational age?
Birth weight is important, sir, because low birth weight babies are more predisposed to complications.
Absolutely. Yeah. Small for gestational age babies, you need to see whether it is a term or
Or
preterm. Small for growth restricted babies are more prone for pulmonary hemorrhage.
bridges.
And why this APGAR score is important, Dr. Lakshmi?
APGAR score, sir, will tell about the necessity for further resuscitation, sir. APGAR will tell you about the APGAR will tell you about the further course of the baby. Like we can just through APGAR we can tell.
In this case, you're talking about term neonate having pulmonary hemorrhage. Anything you are looking at in APGAR score? Why you want actually what condition will lead to pulmonary hemorrhage in term neonate? I'm talking about.
Sir, APGAR will tell us about the intrauterine insult.
What do you mean? That is perinatal asphyxia, isn't it? So if you are dealing with a case of perinatal asphyxia is one of the risk factors for pulmonary hemorrhage.
Yes,
So
sir.
now we are dealing with a term neonate. Now we need to know that what are the conditions which can lead to pulmonary hemorrhage. So one is you said perinatal asphyxia is one important cause. Anything else you think that it is a 37 weeker. It is not a late term. It is an early term baby. Do you
Sir,
think early term babies are more prone for RDS?
sir, usually we don't see term babies with RDS. Early
Really?
term,
Have you shown the X-ray of that audience? First X-ray when the baby
yes, sir.
had respiratory distress?
Sir, we showed the X-ray of this.
Yeah, is this the first X-ray?
Yes, sir. This is the admission X-ray, first X-ray.
What do you think, this baby? Which one is on the? This is before. So is it? Do you think that you felt it as actually a pneumonia, correct? Congenital
Yes, sir.
pneumonia. So
Yes,
what is
sir.
the what? So why do you say it is congenital pneumonia? On what basis you say it is congenital pneumonia?
Sir, baby developing distress after a successful Apgar.
Okay. What are the other possible causes for having this distress at 2 hours of age?
Sepsis.
Okay.
Sepsis can be a cause for this.
Okay, absolutely agree, agree. Sepsis always need to be there. But is there any evidence for sepsis in this? Mother actually didn't have any problem. There was no fever. There was no leak. Why do you think that this is sepsis? If I have a mother having evidence of chorioamnionitis and high vigilance of showing some group B streptococcus, some organism, then definitely I can call, because history is important for us. If there is no history suggestive of infection that can transmit to the baby, how do you think this is a congenital pneumonia? So you also said actually this baby developed distress at 2 hours of age. Agree. One of the differentials for developing respiratory distress at 2 hours, agree. Like your RDS can manifest a bit later, meconium aspiration syndrome, and I agree, all these things. So in this case, looking at this, so you thought of congenital pneumonia. Okay, I agree, because sometimes you may not find any reason. One of the differentials you take congenital pneumonia. Okay. So what exactly you did for this baby immediately after that?
Sir, we immediately shifted on to the NICU and we started him on CPAP. And despite starting on CPAP, he was not able to maintain the adequate oxygenation, so we had to intubate the baby, sir.
Okay. Okay, all right. So, do you think this baby requires CPAP or ventilation? I'm just taking on, because I know that you have done a wonderful job. Baby safe. I just so looking at this homogeneous lung disorder, and do you think CPAP would work in this baby?
Sir, initially we started on CPAP, but
Okay,
within
okay,
when we escalated to higher settings of 6 by 50, and we got this X-ray done immediately. After 10 minutes, we got the X-ray. We had to intubate the baby and put him on SIMV support, sir.
So this is another important factor. Term AGA babies developing RDS, and
Yes,
those in our era, actually they were dying because there was no surfactant available. You got my
yes,
point. So they were
yes, sir.
dying of RDS. So to me, it goes back to my story. Then this baby, term baby, is it? I'm having a very. This is a very. If you look at that, is completely opaque lung, correct?
Yes,
And so to me, more than pneumonia, I think it was a RDS.
yes, sir.
First diagnosis would be RDS to me, and subsequently ventilated. Fantastic, and you give surfactant immediately.
Sir, we were not able to initially, sir. They were not affording, so parents refused for this. But then later on, they agreed.
Okay, 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 good. So now if you take the history here, so this baby was an early term and having distress at 2 hours could be possibly RDS, and you did an X-ray. X-ray showed actually the completely opaque lung, and then you ventilated the baby, and then because that's parents refused. So do you think this, instead of pneumonia, can we take RDS as the first diagnosis here?
So yes, we can take 2 to 3% term babies do have a risk of developing RDS, sir.
Correct, So you need to analyze yourself that whether I'm dealing with pneumonia, because pneumonia I don't have any reason to think of, because antenatal history is fantastic, isn't it?
Yes, sir.
And there was no, it was not an emergency case also. Think of something meconium, they don't say meconium aspiration, but here completely homogeneous lung. It is not a heterogeneous lung disorder. So to me, actually, this looks like an RDS, worsening RDS in early mother. Anyway, I don't think that mother received steroids. She's just presented at 37 weeks. Correct?
Yes.
Absolutely. Okay. All right. Um, so then, okay, that's one part. I was thinking that some in between, but it is fantastic that RDS. After that, what happened? This baby you gave you delayed surfactant, and immediately switched over to from conventional ventilator to high frequency. Absolutely correct.
Yes.
So, do you think that switching over to convention from conventional to high frequency without giving surfactant, does it improve?
Yes, sir.
Okay, and in between that, what happened? Pulmonary hemorrhage you got just before high frequency.
Pulmonary hemorrhage happened just before high frequency. Yes, sir.
What does it indicate? So pulmonary hemorrhage here because of the lung disease rather than your what is called as sepsis, isn't it? So then
Yes.
you eventually put the baby on high frequency
High
oscillator.
frequency.
Then it started doing well. So did you give surfactant at that point of time?
No, sir. After 2 hours.
Okay, anyway, you give surfactant, isn't it? Once the baby put on high frequency oscillator ventilation, you give surfactant also. And baby started to improve, you said, correct?
Yes. Yes, sir. Yes.
What does it indicate again? Do you think the sepsis will improve so fast if it is a congenital pneumonia?
No, sir. It will not improve.
Starts worsening. So basically, I think I'm very happy today I'm here because I am just seeing a case which I saw long back. A term neonate presenting with RDS, having pulmonary hemorrhage. Nothing we had at that moment. Only we had what is called as conventional ventilator, which was not syncing. There was no non-synchronized ventilators we used to have. All babies used to be on IME. Either they used to go for pneumothorax or used to go for pulmonary hemorrhage. So here, actually, this baby most probably, had RDS and then improved with your high frequency and then. Okay, why did you think high frequency you thought of pulmonary hemorrhage, or is it because you kept very high on conventional ventilator but not saturating well? That was the reason for the baby to go on to the HFO, or is it something you felt bleeding and then you thought?
Sir, it was the failure of conventional ventilation, which eventually we had to transit to the HFO mode of ventilation, sir.
Acha, acha. So usually pulmonary hemorrhage, classically, at what point of time they develop? Is it before 72 hours or after 72 hours? What is the usual trend?
Sir, usually before 72 hours,
Yeah. Usually in your case also it was around
at
72 hours.
13 hours of life. Yes, sir.
So that is the common reason. Suppose if it gets delayed a bit later, what would be your reason? Usually,
Sir, it can be after surfactant administration also. We can have delayed pulmonary hemorrhages, sir.
why do you think surfactant will cause delayed pulmonary hemorrhage?
So,
Usually, what will happen? You will not find surfactant deficiency. You cannot say that surfactant will cause. You cannot. Is not a cause for the association. There is no cause. So, what exactly will the basic lung disease will cause? But problem with surfactant, it is going to improve pulmonary circulation. So, when it improves, the left right shunt will be more. That is the reason pulmonary hemorrhage happens. Otherwise, surfactant should not be blamed actually, because surfactant is one of the important therapies. If you see multiple trials, it is done to either to improve your oxygenation index and to prevent the relapses also. Recurrence of hemorrhage will be brought down. That's the reason you said after that it stopped. Why did it stop? Surfactant is going to prevent the recurrence of bleed. That was the reason actually how this baby improved upon. Okay, all right. So, and also the high frequency. Why do you think that high frequency will work for pulmonary hemorrhage?
preventing barotrauma, sir.
Okay.
There are small tidal volumes, so and eventually the pressure attenuates till it reaches the alveoli. So barotrauma is prevented by high flow, sir.
Is it only barotrauma or anything else? It will help. When you put the baby on high frequency oscillator, what is the mechanism in which bleed will stop?
Sir, it will prevent air leaks and
Ear leak is you're talking about only the lung parenchyma. Anything
yes,
else it does. In addition to lung parenchyma, lung also has got capillaries.
sir, high map.
So it's going to tamponate the capillaries, correct?
Yes, sir. Yes, sir.
So the tamponate phenomena of high frequency will actually prevent the bleeding, correct? That's how the pulmonary capillary pressure they stop bleeding. Okay, so was it a massive? Do you think that volume of bleed is important here? When the baby had pulmonary hemorrhage, did the baby go into shock?
That time baby didn't go into shock, sir.
Okay, what does it info you?
It was not.
So that means it is not so severe to cause shock. That means you need to always quantify the blood that
Right.
was actually, because you get, there is an entity called massive pulmonary hemorrhage. So in most of the Western people, what they do is they have a chart saying that in all ventilated babies, especially preterm babies, they keep looking at pinkish aspirate in the endotracheal tube. She'll document it. Pinkish aspirate. Please kindly do echocardiography to look for any pulmonary edema because of left to right patent ductus arteriosus. So they, it is always look at the amount of blood that is coming. Most of these babies actually they succumb. You cannot intubate the baby. Suppose if baby starts to bleed, if the endotracheal tube comes out, and very difficult to look at the laryngeal area and then intubate. So most of these babies they die in front of you. Correct. So here what you need to look at is what is the amount, and whenever you see sudden desaturation, sudden heart rate coming down, blood pressure starts coming down so fast, then it will be massive pulmonary hemorrhage. So in your case, it was baby was maintained everything, heart rate, blood pressure, capillary refilling time, all these things are fine. Correct. That
Yes,
means
sir.
it was not massive pulmonary
Massive
hemorrhage.
pulmonary hemorrhage.
Correct. So when did this baby develop shock?
Sir, on day of life 3.
Why do you think so, baby doll? Because you gave at this moment surfactant and then high frequency also. No?
Sir, CRP rose. We were suspecting sepsis only as the cause of shock, sir.
Okay, okay.
We were
But
suspecting
yeah,
sepsis.
yeah. But none. So, which type of sepsis you think that so fast catastrophe will happen? Do you think there is a gram negative sepsis or gram positive?
It's a gram negative sepsis.
Okay, gram negative. So, do you think that they don't have any impact on this platelet and then counts? But counts and platelet count continue to be okay, no?
Yes, sir. Yes, sir.
And was there any change in the lactate level?
Sir, after HFO, actually lactate improved. Initially, it was 2.6. Later on, it come at to 1.5, and eventually, we were able to target 1 lactate.
Okay,
The
I agree.
corresponding.
See, at this moment, anybody at this moment, you should think of sepsis. I think a wonderful job you have done. And then you went on to the this one. The only thing, the mechanisms, how it works, you should remember. And also the analogy, in the sense, the sequence of things. So suppose if I want to analyze a child, you should always look for the history because we are all standing on history. Baby doesn't give any information to us. We all
Yes.
gather the information and then act on that. So in your examination, when it comes actually, I think it is a term RDS is the important diagnosis to make. Of course, these babies on in the NICU for a long time and then may get infected here and there. That's there. CRP goes. CRP going alone up will not give any evidence. By this time,
Well,
they could have developed some amount of culture positive sepsis, but it was not there, isn't it?
yes, sir.
Okay. So I think okay. So in the HFO high frequency oscillator ventilation. So anything else you could do? Anything else? Suppose if you think that bleed is so high, what other things we can do? You put the baby on high frequency. You increase the map. Usually they keep around 10 map or suppose 2 3 centimeters water above your convention. All these things are okay. In addition to that, anything else you could do? Any evidence, anything else, any medications you can give into the endotracheal tube if there is a bleed?
Adrenaline.
Adrenaline, yeah, absolutely. So
Adrenaline.
endotracheal adrenaline, because there is a vaso. I want actually this
Yes.
baby to have vasoconstriction. So intratracheal adrenaline is around 0.5 to 1 ml per kilo. You can easily give into the endotracheal tube.
Endotracheal.
Keep repeating 1 to 3 4 times depending upon that. Is one thing. Though there are no, what is called head-to-head randomized control trials, all these things are on your case series, case retrospective studies. Otherwise, there is nothing actual randomization in this case. Correct? So adrenaline has got a role in this. So, and then you got HFO has got a role in this. Surfactant. So, adrenaline again, since it is not something because there was no massive pulmonary hemorrhage. Correct?
Yes,
Anything
sir.
else you gave? Did you look any other thing? The causes you need to think of. Suppose you think there's a baby with a bleed in a term unit. What are the other causes you need to think of? Anytime you did echocardiography,
We didn't do echocardiography.
why echocardiography is important here? Why do you think echocardiography is important in pulmonary hemorrhage?
Uh,
Because you have what is called term PDS also. We had a baby, a 36, 37 week, I think Nidhi was not there, just before Nidhi joined us. So this baby came to us with pulmonary hemorrhage, and it was a big ductus left right shunting. So always, all pulmonary hemorrhage babies should have what is called as echocardiography done to look for left right shunting or too much blood. And these babies sometimes they come with massive pulmonary hemorrhage. Immediately, you cannot try with your medications like your ibugesic, indomin. No, we have to ligate this baby as early as possible after stabilizing. This is very, very essential. Anytime baby required any blood components,
Sir, we gave FFPs for the pulmonary hemorrhage.
uh, so do you think that, so what was the, so you did some of the parameters or just because of bleed you gave? Anything you checked for PTA, PTT, INR?
Yes, sir, we checked for coagulation profile.
Ah,
That was more or less normal, but we gave
normal.
FFP.
Okay. Anyway, so bleeding unit, you didn't want to take the chance. But
Yes,
actually
sir.
speaking, you need to have platelet count, you need to have PTA, PTT, INR. And did you give
And
vitamin K in this case?
vitamin K we gave, injection vitamin K we gave.
Okay, fantastic. So I think, yeah, these are the important things you need to look at. So, but very important for us is these pulmonary hemorrhage babies, myocardium is so much injured, sometimes they get what is called as left ventricular dysfunction. And you need to assess left ventricular dysfunction in any pulmonary hemorrhage babies. Okay, because already this acid starts accumulating. So your baby, I think what take home message here is history is very, very important. You have to give all antenatal histories. Second thing is you need to look at catastrophe happens less than 72 hours. You need to look at UGR, respiratory distress syndrome, sepsis, coagulopathy, and PDL left right shunt. And always you need to think that any bleed, you just watch for all the vitals, heart rate, blood pressure, capillary filling time, lactate level, urine output. Make sure that baby is not in shock. And that, because if the baby is in shock, if there is a massive pulmonary hemorrhage, need for high frequency oscillator ventilation, poor prognosis, if not rapidly treated. It's very, very important take home messages here. And other things I was thinking, imaging, very important. You showed me the image, just X-ray. That is an RDS one. After that, it started improving. 2D echo is very essential in all babies with pulmonary hemorrhage. And outcome, very important. Time to you need to know the time to stabilization. This will give you a lot of information to you. How early I could stabilize. You could stabilize the baby within few days.
Yes, sir.
Because the reason what if you put the baby on you gave surfactant, you put the baby on HFO and baby did well. So what does it
Yes.
indicate? It is a something acute insult. It is not something going on. Because rarely, sometimes you get what is called as lymphangiectasias in the lungs. Sometimes vascular malformations in the lungs. They start if you don't have any reasons, you need to do CT and look into that if there is any lymphangiectasias and or any hemangioma. That is very important to us. And of course, did you screen for ultrasound brain and all?
Yes, sir.
You
We did
did.
a
Fantastic. Any one part of bleed, you should see bleed elsewhere, especially intraventricular hemorrhage, and subsequently you need to look for periventricular leukoplasia. And especially another important factor in bleeding is when you do suctioning, you should be very, very careful. When you
delicate.
want to remove the clot, because sometimes people they go and then start actually pushing in and out the tube that it causes massive pulmonary hemorrhage again. This is another important. Did you get any volume bolus here?
Bolus.
Volume bolus because baby had pulmonary hemorrhage. Is there any evidence for this one? Volume bolus? Did you give any volume? What type of shock it was?
Sir,
Is
it
it
was.
something hypovolemic or is it something cardiogenic?
Sir, we were suspecting septic shock only
Okay,
that time.
so distributive shock.
Yes, sir.
You didn't give any boluses.
That
It was
time we
not
didn't give any
it was
bolus.
not need to give, correct? Okay. So vasopressors, which one you chose? Vasopressors, I don't think you gave. Which actually you preferred?
Adri. We started with Adri. Cold peripheries. Cold.
So and I think the ventilatory mode also you. I think so you need to have an open mind and you need to analyze and then treat it. I think you do wonderful stuff. I think it's all from my side. Nidhi and Dr. Monica Sharma.
So, thank you so much, sir, for opening up the case and making us learn exactly what could have happened, what could we have thought of, and we would be more careful in doing the things. We have
Yeah.
learned a lot, sir. So, would you like to give us about any session on HFO, sir?
Yeah. See, basically, okay, high frequency oscillating ventilation, as name mentions, it is frequency is on the higher side, and the volume what you give is sometimes very close to the tidal volume at the level of nose. So that is the only small amount of volume you give, but frequency is very high. And the concept goes back to what is called as, you see that the high frequency, especially the dog creates high frequency, isn't it? Similar to that, actually, they wanted to have a concept of putting on these babies, especially it is not something related only to babies. You can do even adults also and babies also, and because the panting phenomena that you see in dog, which actually revoke this concept of high frequency oscillative ventilation. It is not something when everyone should have high frequency oscillator ventilation. It is all man behind the machine. So if you have a conventional ventilator and then you are doing good job, that's fantastic. But if something goes away on conventional, you have gone up to the maximum level of conventional ventilator, you know that some of the baby is not responding well enough. For example, it could be a homogeneous lung disorder, heterogeneous lung disorder, and or associated with PPHN. And these, and especially if you are going up and up on conventional ventilator, what you see is either pulmonary hemorrhage or pneumothorax, airlick syndromes. When you suspect that these babies whether can get benefited on HFO, you have to put these babies on HFO. And what is important in HFO is the machine what you use. Sometimes some of the machines, you take baby log, they each machine acts differently. As Dr. Laksh was talking in about rightly about this HFO, especially working on independent phenomena. That means when I want to oxygenate, I'll just move the map. When I want to look at ventilation, I look at only what is called as amplitude or frequency. So what important with this is there are, you need to know that they have different mechanisms acting on that. So what we see in conventional ventilator, what we see in high frequency is entirely different. What we give in high frequency is called bulk flow, 20 liters per minute, maximum flow that comes into the ventilator. And when it comes into the ventilator, because it has to oscillate, so it has to oscillate, you will find what is called, there is a speaker. So it has to move forward and backward. Forward. That movement is very important for the thing energy to generate what is called as amplitude. So the map basically depends upon your 20 liters per minute. And what exactly happens here, you will find there are different mechanisms. I don't think that theory is not important here. A very important concept here, which I would like to know is that Pendeleft effect, very important. That means when when there is alveolar ventilation happens, actually, some of the alveoli are atelectatic. This phenomenon happens actually because there is uniformity in the map, which we don't see in the conventional ventilator. Conventional ventilator, what happens is a shearing moment. It squeezes, it inflates, deflates, which can cause a lot of injury to the lung. But in high frequency, it is you are creating only map. It is just there's no shearing effect on the lung, so you get what is called less swallow trauma, or trauma, and all. But here, what happens? Some of the alveolar deflated, and there is a movement of air from one alveolus to another alveolus, making the other alveolus also inflated and keeping the time constant, forever constant in all the alveoli. This is a very important phenomenon. Of course, the movement of the air, whether it moves in the center or it moves in the periphery, also makes the exchange of gas that happen, mixing of the gas that happens. Here, really important is active exhalation. So here, both inhalation, inspiration, exhalations are active. So usually conventional method, we don't see the active expiration. So with the mechanism of all these things, what exactly we need to look at is adjustment. Suppose a baby, now I'm getting a baby from hospital, and baby is on conventional ventilator, around 20 of PIP and rate of around 60 and FIO of 80%, and then inspiratory time of around zero point 0.4. So I now this baby is not doing well, and they have gone up to 27 also. Now at this moment also baby is not doing well. I need to tell my nurse who is I'm handling the HFO in my unit. I need to tell her how to fix this, how to keep the parameters before I come to the unit. So she will give very important to that. There is a constant factor, and there is what we call a dynamic factor and static factor. So dynamic factors are essentially the map and the amplitude. These are only two important things. Of course, the FiO2 you always get. So what is static factor is your frequency. Frequency is a static factor, and then your inspiratory time. So you keep around 30, you keep 1:2 ratio. You keep that one. That you don't change it. Now what happens when a baby comes to you? I need to look at the X-ray whether I am dealing with a case of homogeneous lung disorder or heterogeneous lung. Now I see in that unit, it is a heterogeneous lung disorder. It is a meconium aspiration syndrome baby. Some areas are epileptic, some areas are hyperinflated. Now I shoot this baby. I tell the nurse, this baby has got what is called as meconium aspiration syndrome. Some areas are already hyperinflated. I'm worried about keeping more map. This map on conventional elevator is around 14. Keep around 14 only, don't go up. Because if you increase also a problem. If you increase, what happens? Those hyperinflated alveoli may get open and air leak will get. So I keep that there. If it is a pneumonia, I can keep a bit 2 to 3 centimeters above. So I'll keep that map around the same or high. If it is a homogeneous lung disorder, for example, it's a completely white out lung, then you can go up from 3 to 4 centimeters above the conventional ventilator map. I'll keep that. Now, FiO2, I'll look into that. Next important thing is amplitude. Very easy. Suppose if I keep map of 12 or 14, I'll tell the nurse, keep around 2 times the map. That will give you the amplitude. So amplitude, anyway, you need to look at clinically also when you come to the unit, when you attach the baby onto the ventilator high frequency, you look at what is called as wiggle moment. Till just below the umbilicus, you can see, or at the level of umbilicus wiggle. The baby cannot wiggle too much also. So now I keep around 2. Maximum how much I can go? I can go 2.5 times the map, not more than that. So I also come and see the baby clinically. Then once I do this map and amplitude, that's what I'm interested, because already constant factors are already there. The frequency set. Remember that extreme preterm babies, if I see, I keep more frequency. If it is a term neonate or a pneumonia or something like that, better to keep around low frequency. So around 8, 10 something. So if it is like a 28 weeker and bad ODS, not maintaining good on conventional ventilator, then I'll go to what is called 12 to 15. 15 is the maximum frequency, because the reason is the frequency of preterm lung is very high. That is the reason you need to keep high frequency. And once you set high frequency, please don't touch that part. Now what I do is map your kept amplitude and your adjusted FiO2. You must have kept around 60 to 70% FiO2. Half an hour after that, we have to do what is called as chest X-ray and blood gas. Chest X-ray, if it shows more than 8 posterior spaces, if it is more than 7 to 8, then there's a hyper expansion. Then I need to bring down the map. So most of the times, actually, what happens, oxygenation is not improving. What fellows they start doing, because the conventional teaching is, if not maintaining, go up with the map. What the fellows do, 80%, 80%, they start increasing the map. When they increase the map, what will happen? Baby starts to have more and more oxygen requirement, because venous return is reduced and baby is going into hypotension, and they start increasing. Moment you reduce the map to what is a lower level, cardiac output also will improve and saturation. This is very, very important for map. So you kept map, you got amplitude, and you do blood gas. If the blood gas is maintained between 35 and 45, I think I'm very happy with this. Or a bit more, till 50, I'm okay. So you keep the carbon dioxide level, only amplitude you go up or come down. Here, what happens actually is the frequency you're not touching. Suppose you've got up to amplitude of 2 to 200 times the map, but still carbon dioxide is on the higher side. What you'll do? You have to bring down the frequency. Very, very important. Now you're gone. Don't keep on increasing the amplitude. At one point of time, you reach 2.5 times, but baby's carbon dioxide still on the higher side. Then I'll reduce the frequency. You can see that what will happen actually in conventional ventilator, and we increase the rate. But here, the high frequency, what will happen? The frequency has to be brought down if there is a building of carbon dioxide. It's very, very essential to know. Otherwise, we are not going to touch. Now, once the baby reaches a good saturation, what we'll do is I'll start. Now, you know that I brought the baby here. I put the baby on high frequency oscillator ventilation. I know humidification, very important. I'll give importance to humidification here. If you dry the baby's airway, they go into what is called as the necrosis of the trachea and bronchi. It's very, very important. All the nurses should know that on high frequency, the good amount of water should be there and the humidification system should be good. Now, I know that I put the B1 map of 24 and then amplitude of around 35 or 40 and then frequency of around 10 and 1 is to 2 ratio, effort around 70%. Now what I do is, baby is saturating well. Now I start coming down, not with the map. Map don't disturb. We start dropping the FiO2 till 40%. Once it reaches 40%, keep 40% of FiO2, then start dropping map. For example, if it is 24, come to 22, 20, so slowly you start coming down. Once you reach around 12 to 14, then keep the map there only, then start coming down with your FiO2 requirement. Once it reaches 30, keep 30 and drop further. And most of these around 10, you can take the baby off ventilator to conventional ventilator. You can switch over. Or if you can come down to 10, 7, 8, you can come directly from HFO to CPAP. That's how what exactly happens, the switching over what happens. So here, always every child should be starting with wiggle, and as you keep moving towards the end, wiggle should go away. Because why wiggle goes away? Baby is spontaneously doing on its own activities. So start with wiggle, end with no wiggle is the concept of high frequency oscillation ventilation. I think it's too much time I'm taking.
No, sir,
I know
please
it's too.
continue. We are very interesting discussion. We are eagerly listening. Please, time has.
Oh, thank you so much. So basically, we need to monitor the blood gas. We need to monitor the oxygen status in this baby, and these babies they really do well. And again, in PPHN, there's no role of putting the baby on HFO. Suppose if you have HFO with nitric oxide, sometimes for pulmonary hypertension, because these combinations will work. And most of the teams remember that HFO, when you put, you should be very careful. Blood pressure should maintain. If blood pressure is not good, if the baby is very hypotensive, and putting the baby on high frequency sometimes will cause more harm than this one. And most of these, I don't know, sometimes whatever evidence we talk, and we know that this high frequency will not work on the baby. I had a baby with a perforated lung, perforated gut, and this perforated gut actually caused, there was an intestinal perforation. And it was a preterm baby around 29 weeks. I think Nidhi was there. Yeah. So, and this baby, we put the baby on ventilator. Conventional didn't work at all. Baby was hypotensive, tachycardia around 190, 200. Then we thought actually there was no option. We put the baby on high frequency. Baby started saturating very well. And then I spoke to the anesthesia people. Please operate on HFO only. Please operate on HFO only. But then they said, no, we cannot operate. Then switched out conventional. Again, baby became bad. Yeah, baby had to be operated on HFO, and baby did well. So we don't know at what point of time HFO works, but anyway, it worked well. But what is take-home message is every ventilator is safe. Every ventilator functions so well as long as the physician behind the machine works well. You should know the physiological concepts very well to handle. And we have people, they burn their fingers using high frequency oscillator without actually knowing the basics of high frequency. And unit doesn't have high frequency should not get disappointed. They can do wonderful job without that also. And if you have, it's wonderful. You can you can say that I have an added advantage. That's the only thing. And at the end of the story, I think I congratulate Laksh Sharma for a wonderful session today. I learned a lot of things from Laksh. And thank you so much, Madam Monica Sharma and Dr. Seema, Dr. Nidhi Gupta, and Dr. Naran, Fantastic. Thank you so much.
Thank you so much, sir. I think we have learned a lot from you. I think it was really nice that Nidhi suggested that we should have Dr. Venkatesh as the expert, and we are really happy to have you here. Thank
Thank you
you.
so much, ma'am. Thank you so much.
Thank you
Thank you.
so much for excellent session and in-depth discussion on very minute details of HFO, how to take on off the ventilator, how to suck. These are very minute things which plays a very important role in overall outcome of newborn. Thank you so much. If any resident, delegate, senior pediatrician, or yeah, I request Dr. Dalochan Singh Dawa sir for any inputs or final comments or any questions. Everyone is more than welcome. Any input from Dr. Narang sir?
Actually, this was a very good learning exercise for residents. And what I feel, as already said by someone, that we can have a separate session from Sir only. Actually, I also want to learn regarding this, but we are almost outdated now. The new at our time HFO and that was
Yes, sir.
not there.
Understood. Understood. Yeah.
Want to learn this thing, Doctor. I congratulate Dr. Monica and her team for such a good presentation.
Thank you, sir.
Okay.
Right.
Sima, I think if there are no questions, we can conclude.
Okay. So at the end, I extend my heartfelt gratitude to speaker and expert of the day, Dr. Venkatesh sir, senior neonatologist from Manipal Hospital. Thank you so much. I thoroughly enjoyed your discussion. Thank you so much, sir. And I also extend my heartfelt thanks to Dr. Monica ma'am and Dr. Nidhi and Dr. Lakshay for accepting our invitation, taking so much effort in making the whole case very much interesting, and it will be a very learning point for all the residents who attended online, and this will be also available on our YouTube channel Sapa. So maybe recordings will be available for each and everyone who couldn't join. Thank you so much. I extend my thanks to Dr. Narang sir. Thank you everyone, and our EBs, Dr. Ruby Singh, Dr. Radha, and if I'm missing, I apologize. So I'm extremely thankful to everyone to make this discussion a wonderful one. Thank you so much.
Thank you. Thank you so much.
Thank you.
Thank you.
Thanks.
Yeah. Thank you.